Hi, good evening, friends. I hope you can see the MRI. This is a patient who has undergone a prior discectomy at L4, L5. That is a fixed retrolisthesis at L4, L5 with a calcified disc. And then what we see above at L3, 4 is a fresh herniation with a little bit of angular instability. But there is no translational instability. So I think I should give the patient the option of a discectomy prior to thinking of any fusion. So, welcome to the OT. And Priyanka, can you also focus on the plane X-ray? Show them the flexion extension views. Okay. And then can you please now zoom out and zoom on to us? Can you put on the OT lights, please, so that we can show what we are doing on the patient's back? Zara focus kara ikade light. Thank you. And you can see over here the scar on the patient's back of the previous surgery from here to here. Now, I'm going to use a marker pen to first mark the midline. As far as the OT setup is, we have a C-arm in place. We have our monitor over there, and you will be able to see the scopic view shortly. We've done the white balancing. We've kept the scope ready to enter, and we will start with the surgery. So let us take a C-arm shoot. Let us take an AP and mark the AP line. Can I have a C-arm shoot, please? Hello. प्रियंका जरा तिकडे लक्ष दे. We are just booting our C-arm, so we'll wait for that. As you can see, I've got two probes on my table. I normally work with a 90-degree probe, and I work with a curved probe. This is a curved probe, okay? And please give me the 90-degree probe also. This is the 90-degree probe. So I usually use two probes. Both are on my table always. I also have a burr connected. It's a simple orthopedic burr. I prefer to use a fine diamond tip burr rather than an aggressive cutting burr. It's better to be slow, but better to be safe. On my this hand over here, I've got the connected scope. So we are ready, and now we are waiting for the C-arm. Shoot गए ना भाऊ. Rotate करा प्रियंका जी. So we have a basic shoot now. Priyanka will focus on the C-arm to show you. Priyanka, please connect the. John, please keep your head out of the way. Shoot, please. No, we are a little off. So shoot, please. Mirror karo image, please. Please mirror the image. Shoot, please. So we are marking the midline. Old scar is slightly off the midline, but we are bang on the midline. And we have to go mirror करायचे, rotate नाही करायचे. Rotation बराबर होतं, फक्त mirror करा. Shoot, please. Shoot, please. Shoot, please. Shoot, please. So that appears to be our mobile segment. I'm marking the disk and I'm rewriting disk over here. We will confirm that same segment in the lateral. John sir, please come in lateral. It has to be the second mobile segment from below. So One advice, gentlemen, don't depend upon bucking. This is a specially designed drape by me. It's a single drape that incorporates everything. Normally we have a screen sheet up here, but today because you have to see, I've kept it down. And now I'm going to keep myself roughly in line with the disc. And can we have a shoot, please? Shoot, please. Shoot, please. Shoot, please. So roughly somewhere here. Shoot, please. This is my mark on the back of the patient, and it roughly meets over here. So come in AP, please, gentlemen. Priyanka, can you focus on the skin now, please? खाली कर, आरामाने कर, जॉन प्लीज. रिलैक्स, काम करून काम करा, काही घाई नहीं है. Level confirmation, very important in any spine surgery, and more so in endoscopy, because once you go wrong, you go totally wrong. So come up, and this is where our lateral mark, and this is where our back mark is. So shoot here. This is exactly where we want to be. So thank enough that this is our spinolaminar junction. Shoot, please. See, I'm at the spinolaminar junction. Now I'm going to mark the upper pedicle. Shoot, please. Can you see the lower border of the upper pedicle? Yeah, I'm marking that. And I'm going to mark again the middle or two lower border of the lower pedicle. So shoot, please. Followed. So this is exactly where I want to be. Now I will mark the medial pedicular line. Shoot, please. I'm a little out, come a little in, and we take a mark. Shoot, please. So this is the medial pedicular line that has been marked by me. Now I will take two needles to complete my triangulation process. I believe in using needles because they give me a more accurate sense of where I will enter, where I will reach, how I will reach. So now we come in with the first needle going to the spinolaminar surface. I can hit and feel bone. And now from the second needle, try and triangulate towards the first needle. Shoot, please. There, we are triangulating on the back, but we are a little above, away from the spinolaminar junction, so we'll move both downwards. Shoot, please. Yeah, the lower needle is quite close to the spinolaminar junction. I'm walking on it to feel it, and I'm shifting the lower one also a little lower. Shoot, please. It's a little out, so back we go in. Shoot. Yeah, that's the triangulation point. Quite like it. Obviously, the lamina is lower and the disc is high, so some amount of laminotomy will be needed to reach this fragment, being an L3-4 disc. Can I have some infiltration? I'm going to be using saline with adrenaline. And see, when I'm injecting, can you see water coming out from here? Can you zoom here? See, saline coming out here. So that means it's a pretty good triangulation. Now, why I'm pushing in so much fluid is so that I create a sort of a lake over there, which elevates the tissues. And I'll just wait for the pressure to dissipate a bit and then come out. Can I have some more? So far so good. And now we are infiltrating from here. And we are going to increase the area. So just in the muscle mass also, I want some infiltration. And now I'll be pulling this needle back also to give some infiltration into the muscle mass. Some more, please. Good amount of good infiltration done well is a boon to the surgery. It will help me demonstrate a cleaner surgery to you guys. So thank you so much, and we will wait for about 30-40 seconds for things to act. Now, I prefer to take the instrument portal first. Many people ask me, why, Dr. Malcolm? The reason is that when I put in my pipes and my cut is a little larger because I believe in higher flow rate rather than high pressure inside. Now, that is a concept we will discuss when we meet face to face. And I'm pulling this needle out and I'm taking a cut which will be approximately a centimeter. And from inside, I will move towards the spinous process to release the fascia on the spinous process. But you see, I'm only half blade in. That is because my fascia is that much. So I've just crossed the fascia and now I'm dilating the muscle path and going inwards. Can we have a shoot, please? See, I'm at the spinolaminar junction. When I do this, you can see that my dilator suddenly slips in. And then when I come up, you can see that the dilator slips up. So in, up, in, up. This is the spinolaminar junction. I will be using a dilator number 2. Can you take the machine back, Mr. John, a bit so that I'm comfortable? Thank you. Now dilator number 3, and then we'll go to dilator number 4. Sometimes I even use the 5th dilator. I prefer to use a very good egress channel rather than a tight egress channel. Now that means that I will have less pressure inside, for which I have to compensate by using higher flow, which does not really worry me or make me feel bad that I am using a higher flow because I feel I am doing the right thing. So I am stripping away up and down with my pipes the paraspinal musculature from the back of the patient. Can you bring it in front, John? And can we give our viewers a live shoot? Shall we start? See, now this is the whole width. I'm spanning the whole interlaminar area along the spinous process, little out also, little in also. Thank you. That's enough. And now we will leave these pipes here. Why? Because they will have a tamponade effect. And in the meanwhile, while we were doing this, the local was acting and the adrenaline was acting on the scopic portal. So now see, this is where the fascia is. Can you see this, gentlemen? Fascia. And through the fascia and towards the midline. That's it. Now, we are going to use this to hit this pipe. I can already feel this pipe. Can you hear it? Tick, 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 tick. And I'm going to slide down by the side of the pipe. My triangulation is done. Shoot, please. See? So, now give me again a live shoot, John. Now see, I'm going to move these together so that the tissue between these two is gone, is elevated. So I have elevated tissue. I have not cut any tissue. No multifidus has been cut because multifidus doesn't come in this area where I'm working right now. And now can we have the table a little low, please? And the machine a little back. Now, I'm not happy. Thoda yada over banda. Bas, thank you. Now I put a scope guard. Can you see the scope guard in front of the scope? And now we'll bend my finger a little more lower, ma'am. I want to be comfortable, so we'll go a little lower. Then at the time of an X-ray, we'll come up. This is the lowest. Okay, we accept. Now what you see here on the screen is my finger, which is bent. And you can see the crease of my finger. You can see my scope is aligned. My finger is nicely vertically seen. It means that my scopic orientation is perfectly at 90 degrees. And now I can easily introduce this scope into the patient's back. So I gently slide it in until I hit the bone. And now we will start the pump. I prefer to use the pump, whatever people may say. It has been my constant support for over 5,000 cases and I've had no problems. So now shall we start the pump? But like I told you, the concept has to be of higher flow rate, larger escape channel rather than small escape channel and have low pressure. So is the pump on, please? Okay, now we remove the pipes one by one. नाही चालू आहे बच्चा. Mama, आता चालू झाला. There was an air trap. शपथ खाल्ली आहे लोकांनी. बदलशील का त्याचं तोंड बघत राहशील. Thank you. So now let us see. Let us do the triangulation. Yeah, we have done the triangulation. Can you see here? The face of the probe. Let's start with blue, please, which is the coagulation mode. Near the lens, please use the coagulation mode and create space for yourself. Now you see one more thing. My hand where I'm holding the scope is so gently as though the scope is resting on bone. I'm not even gripping it. It's just resting on my hand. So be gentle with it. Try not to move it. The only thing that moves is your fingers in a pencil kind of manner. Now can we have some yellow? And move the Siam machine back a bit. Come on, shoot please. Areba. Yellow please. Blue dabo. जरा ते पेडल बराबर दाबो बाळा. पेडल बराबर दाबो. पाय बराबर ठेव. थँक यू. नर्वस होऊ नका प्लीज. सर्जनने नर्वस असायला पाहिजे की तुम्ही? युजलेस आहेत तुम्ही लोक. And now we are coming to the interlaminar area. Can you see this? We have gone into the interlaminar. Now how much of muscle have you actually seen? Any of you? How much of multifidus have you actually seen? Any of you? Come on. And yet everybody says no, 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 no. Biportal, so much multifidus is cut. These are all interlaminar tissues, gentlemen. What you normally punch out in an open surgery and you don't even think about it for a second. I am stripping those poor tissues. I am exposing the spinolaminar junction nicely. And there you see, we are cutting away upwards also a little bit above the scope, this facial envelope. Huh? And there I can create some more space as I keep going up. See? Multifidus. People say multifidus. Where is the multifidus? We are beyond it, buddies. And see now, nicely we are in. We are stripping beautifully. And that you gentlemen seeing is the flavum. Some facetal capsule and some flavum. And believe me, I'm using very low power on my probe. Priyanka, you can even zoom for a second on the machine, on the Endovision machine. And you can show people that I'm using very low power. Now, outer layer of flavum going, inner layer of flavum being exposed, and I think we will come out to clean our probe for a second. Hmm? The scar tissue from the previous surgery, we are not aware how much the surgeon had come up, so that we are in the zone of a redo surgery, so therefore we have to be very careful. Everything looks the same but may not be the same. So gentle stripping, continuous movement. On the phlegm, never stop. Keep moving. काय झालं? पाय का हलवला भाऊ? थकले तुम्ही? Now see, what you would normally clean with your punch so fast takes me a good 5 minutes to strip. But then I'm not in a hurry to show you a very fast surgery today. I'm in a hurry to show you a good surgery today. So time is not of essence. Effort and planning and systematic execution is of essence today. Okay, guys? I hope you all are enjoying. If you have any questions, please put it on the group chat. Priyanka will tell me and I will be able to even answer you while I'm operating. Otherwise, we will discuss this in the post surgery meet. If you all are interested, if there are any people wanting to ask any questions, otherwise, we all go home and we meet in the Congress. So, I'm slowly stripping away all these tissues. Now, can you give me blue, please? Now, blue shrinks these tissues and helps me control all bleeders. Now, the purpose of not going down too much is because we have to do laminotomy and actually go up. So, why waste our time going down? And now, see, when I'm cutting close to my lens, I'll prefer to do it with the blue rather than with the yellow. Okay? The concept being that blue is a little less heat producing. Tissues shrink away. They also cut away. So I think we have done enough of adequate upward laminotomy, maybe a centimeter. I mean, not laminotomy, tissue stripping, what I mean, in preparation for the laminotomy. Okay. And now I'll use a 4-number kerrison to remove some of these tissue which are stripped. Towards me, please. I prefer to use rotating kerrisons. And you can see how nicely we can catch hold of all this tissue, connective tissue, and just strip it away so it doesn't trouble us subsequently when we are operating. Okay, I quite like this. Now I will use a burr to sharpen up the edges before I go for the actual laminotomy. So base of spinous process here, but start burring please, keeping the scope a little away. John, you can increase the fluid pressure now because we are outside the phlegm and our viewers can get a better view. So थोड़ा पंप प्रेशर बढ़ाओ जॉन. किती आहे आता? वाढवा हो साहेब, वाढवा. काय नाही, थोडं फ्लुइड जास्त जाईल पण माझ्या व्ह्युअर्सना क्लिअर व्ह्यू मिळणार. ओके, try and have a nice, because you're not opened the phlegm. Water fluid is going in, is coming out on the patient's back. You can see that. Priyanka, Can you focus the camera on my patient's back? So you can see that when I use a higher pump, more fluid is pouring out. That is a higher flow rate. That does not mean that's a higher pressure inside. Try and understand the difference. The laws of physics. Unfortunately, when people say, I don't want to use a pump, they don't understand one, how to use it. So I'm gradually burring away nicely, comfortably. Can you see the inner edge? Yes, that's the inner edge of the lamina. We are burring it away nicely and we are going up. First we saucerize and then we verticalize. So this process goes on for about 2-3 minutes. I hope you guys are enjoying this. You need to develop a fine control on the burr. Keep your lens protected and away. So saucerization being done. Can you see the inner edge? Nicely, na? I'm using higher pump pressure. So the phlegm is not open. So there's nothing going to the cord. Hmm? Later on when we open the phlegm, we will bring down our pressures. Huh? This is the facet joint on our side. This is the SAP inner edge. The lateral decompression being done. Okay. So we are reaching the end of our targeted laminotomy. What tissues we had stripped, we are reaching that boundary now. So though it may look like we have burned a lot of bone, in reality we have hardly gone a half centimeter to 1 centimeter up and maybe half a centimeter out. I'll show you the landmarks, anatomical landmarks on C-arm for you to have the satisfaction of knowing, because right now it will look very very big to you because of the magnification power of the system. Give me kerosene please. Stripper दे फ्लेबल कहाँ बंद पडलं चेक करा. Towards me आणि फ्लेबल stripper दे आणि बर चेक करा. बर चेंज करा. मशीन चेक करा. वायर लूज झाला का. You can even use a kerosene, which is what I'm using right now. Thank you. We'll reuse the burr. Don't worry. चालू झाला ना, त्याला थोडं शांत होऊ द्या. There. So what you see me doing right now is going in and doing that little laminotomy to reach the upper edge of the flavum. That is also not very necessary all the time. So I think I'm quite happy with what I see now. Can you see the midline cleft, guys? Hmm? Basospinous process. I'm pulling the scope out a bit. Can you see that? Basospinous process. Flavum on the opposite side, and our side, we still need to do some work. Kerosene. I really need good muscles, which I find failing at my age. So I actually prefer to burr a little rather than use strength. But I want you all to have the satisfaction of both things. So I'm showing the laminotomy. I'm doing on my side now, nothing on the opposite side. Okay. And we are ignoring the base of the spinous process. We don't want to do anything more with it. Okay. So there, you see we are coming laterally nicely. Not too much at one time, but at the same time it should be adequate enough. See what happens when you run after the small things, you miss out on the big things. Yeah. So, can I have the RF Pro, please? Touch blue. See how tissues shrink away, nicely, and that's a beautiful yellow flavum in front of your eyes. Okay, I'm thickening up this flavum for its cutting. You fatten the cow or goat before you slaughter it. So this is something akin to that. I prefer to thicken the flavum. Okay, control every possible micro bleeder RBC that I can. One more bite with the kerosene, please. I feel a little obstruction here. Not comfortable. Yep. Thank you. So you can see the phlegm is still not really separated. So, but that's fine. Now we will do a flavortomy. Can I have the arthroscopic punch? I'm trying to underbite into the facet rather than bite straight. Okay, thank you. So I hope you guys are enjoying this view now. That's the midline cleft. That's the phlegm. We will be using, uh, I'm using a Karl Storz uh, arthroscopic punch to thin out this phlegm and to increase my phlebotomy window. So there you're coming onto the cord, and now we'll shift to a kerosene. Can you bring down the plasma to 2 please? Now when the phlegm is open, pressure also down please. John, touch blue. Thank you. Touch please. So I'm touching away the vessels. Touch please. Touch please. Thank you. Touch please. Thank you. Now kerosene please. Phone number towards me. Somehow phone number is my favorite in the spine. And try and be ergonomical and maximize your effort. There you see me taking multiple punches in the phlegm without coming out. We'll use a disc punch now and get some of these pieces out. Some of them will come out with the water flow itself. And now you can see that the flow of water on the back is absolutely crystal clear. There is not a drop of blood coming out there. So we are debunking 2-3 myths. One is that it can be a messy surgery. Yes, it can be if you don't know what you're doing. But with practice, it becomes cleaner, smoother, and efficient. Let's get all these fellows out. That's the flavum which was attached to our undersurface. There's a little flavum left here. So that is also coming out. Now in the lateral recess and going down towards the traversing exiting route. Thank you. Now, can I have the dissector? And now what I'm going to do is I'm going to pull away the scope sheath and I'm going to lock it up here. Why? Because I want my scope going down. The more closer it moves down, the better it is for me. No? See? पंप से मला आवाज येत नहीं है. जॉन, मला पंपचा आवाज येत नाही आहे. पंप बंद पडलाय. प्लीज कॅन यू चेक? As is typical with all Indian equipment. Yeah, can you see the flow on the patient's back? It's piss fart. Now the flow is increased. Thank you. Now I should be expecting something here. So let us see where we are. Let us see where our fragment is, where our dural edge is, and then let us decide what we have to do for our patient. I think this is a fragment. I'm not sure, but I think this is a fragment. This is not the dura. Okay. Or it could be a swollen root. When things are chronic, then things are worrisome to the surgeon also and to the patient also. So, trying to strip away things. That's a vein. And we'll try and remove some fat here. Come. Reason being, this punch. I want to see the dural sleeve very carefully. This patient is poor fellow. He is a free patient. He's been roaming around to get his surgery done. And this thing is almost now 4 months old. So it's a hard fragment which has not undergone resorption. So I really need to see things carefully. Where is my root? Where is my dura? Where is everything before I progress further? So I'm going to do a little fat stripping. I can even see a band in the midline. Can you see that band over there? Yeah, there's a band there. See? Many people were keen on that crazy butterfly challenge. And this is a lesson to them. Okay, butterfly challenges don't always work. You pull on something like this, you'll end up with a dural injury. Now the question is, what is this? This is also scary. Can I have a punch? Can you see the number of bands? Punch, punch, punch. Arthroscopic punch. Can you see the Hoffman bands attached to this thing? One band gone. One more band. Big band जो मेरी बैंड बजा सकता है. So see, punch. फिर भी डर लगता है. That's vasculature or that's a band. Give me the other arthroscopic punch. It looks like a vein, venous structures. Can I have a dissector, please, again? Now, whether this is a neuroma or this is a the feeling, it feels very hard. It's grating. I'm not sure whether it continues as the root. So the continuity must be checked. What is it? Is there root below here? No. So this is not root. It's definitely not root. Can I have a phone number towards me? Oof. Open house question, what would you do in such circumstances? I would want to see below. So I'm going to open up some more phlegm below, which we had not opened up. Now, can I have a dispunch here again? RF first. This is a very vascular zone. Touch, please. Thank you. Give me an arthroscopic, give me a dispunch here. Yes, encapsulated disc fragment. But we went about it the right way rather than the wrong way. and let us tease it a little. Let us remove all the tissues on it, and let us now get the good morning fragment out. It's very important to know where the root is, where the dura is, what is plastered, what is not plastered. Otherwise, you're asking for deep, deep, deep trouble in this kind of a case. So I'm tending to push it a little upwards. I know it's coming out in pieces, not that it's to my liking. What I wanted to see, guys, is the position of my hand now. What you will appreciate is that there is not a single blind spot which I'm working with. So the key part of this surgery or key part of UB is do not adapt to a technique in which there is a blind spot. There is no role for blind spot surgery. Now that was a loose fragment, but badly adherent fragment. Now I still need to free the dural undersurface. So I'm using the disc itself like a small probe, pushing away all this stuff. Yeah. It's quite axillary also in position, the way I see it. On the axilla, stuck, to be very honest. Badly stuck onto the axilla. Clean. So how much to remove and how much to leave behind is anybody's guess. Ah! See the root? So if you do one wrong pull, the root goes with it. That gentleman is the root, this is the axilla, these are the tags. So when you have chronicity like this, be very, 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 very gentle and very careful. To leave behind something is okay, but you have a tear in not okay. That is the root. Can you see? And how the fragment is trapped around it. With the RF. Touch and go. Touch and go. Touch and go. Touch and go. Nako touch karo without asking me. Now touch and go. I'm going beyond the root. Can you see this? This is the root. This is that thing, the mass that it has formed. Touch blue, which is vascular. Touch blue. Thank you. So we are separating out the root from that tissue now. Very important that we do that. Can you see that? That gentleman is the root going there. And see how things are stuck there. Scary, isn't it? That is the axilla. This is the buncum which is troubling us. Give me a 2 number kerosene towards me. Plasma. जाऊन जरा पायाने मी सांगेल तेव्हा प्रेशर वाढव. Touch and go. Touch. Touch. Stop. Touch blue. Stop. Kerosene. We're going to use a smaller kerosene to cut this. Clear this tissue from around the root. Now you can start seeing the root better, the axilla better, the fragments better, everything better. So all chronic adhesion which was on the root has now been freed by us. And can you see that midline? The silent, crouching dragon, and there's a Chinese picture here. I forget the name. चलो अब मुझे थोड़ा और कैरिसन 2 नंबर दो. And you see the position of my scope, see the position of my camera, see I'm trying to see inwards, okay? And at the same time, now there is going to be a clash of space, so we pull back, we see that. Can you see that? Yes. And yes, see? Slowly, 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 we're removing all this bullshit. When you're struggling like this, you don't struggle. Pick the C arm back, please. The best thing to do is go on the contralateral side and go down and have a look. Can you hold this for me, please? See, so now I'm going to cross over. I'm going to walk to the other side, guys. Can you call Priyanka to please focus on me? So I need a platform there. काय थांबलेत तुम्ही? मशीन पाठीमागे करून काय करणार तुम्ही? जर प्लॅटफॉर्म नाही दिला तर? So now I want to see towards the. I don't have a monitor in front of me today, Priyanka. You made a mistake there. Very bad mistake today. John Mama, समोर monitor का नहीं है? हाँ? काय बोलू मी तुम्हाला आज? दर्शन करू तुमचे. दे 2 नंबरच दे. थांब रे. Okay, there, come. 9, 9, 9, 9, 9, 9. Okay, my guys have forgotten to rig the opposite side monitor, so I'm struggling. They will do it in a jiffy, and then I'll be more comfortable. Always have a slave monitor at your back, otherwise you're going to be struggling the way I'm struggling today. राहू दे. See? Ah, fragment. So, plastered sequestrated fragment. Give me a hook. Oh, in the foramen. Wow, somebody disconnected. Yeah, yeah, thank you. Now I can watch in front of me. Now I don't need to twist my stupid neck and develop a neck injury. Yeah, see this, guys? चलो डिस्पंज दो एक एक टुकड़ा निकालने दो. So, if we thought of this as a simple disc surgery, please make sure you don't disturb the electrical connections. Anybody? So, fragments in the exiting root foramen, upper foramen, not even lower, not traversing, exiting root. Fine, we're clearing it out. You can see there is nothing more there now. I'll go closer for you. Okay, small little spicule still attached, but beyond that, nothing there. See the PLL and see the root. Okay, so small fragment here still on the root. If I can catch it, fine. It's a tag on the root. You can appreciate the mess this patient is in. Come, PLL has also torn and wrapped itself around. Give me a curved kerrison and give me a hook. Again, hook the ball tip. Let us just probe for a minute. So instead of being a simple disc surgery, you guys, this is I think one of my most complicated cases. Now, this is PLLH. Okay, this is all thickened PLL which encapsulated the fragment. Root coming out from the dural sleeve, going here. I'm trying to wrap this, break this wrap around. Unable to. You can see that it's broken, but it's still there. So it needs to go. See the vasculature there, the crazy veins. Angled disc punch. Curved de. Ye de. Give me an angled disc punch also. Let us see what all we can do. Totally unexpected. Totally unexpected. There, I'm coming on top of the cord. Where am I? I'll be careful with my entry because I'm using a curved kerosene right now, a foraminotome. So I'll gradually lower it down. Inevitably, this shit happens. Inevitably. At the last minute, I don't know what happens. And you always get that giveaway. Now, it's difficult to introduce an instrument in the negative angle, but when you over a period of time do get the hang of it, and then you can manage it. I don't know whether I should go for it now. It's badly adherent to the root. I think we freed it from one side and it's too badly adherent there. I think I'll have a root drop or a tear. I'm not going to pursue that. It's criminal to pursue that. Let's look up and give me a dissector, please. Give me a dissector. केरिसन देख और जरा मोटा दे. this punch. Yeah, नहीं straight दे, straight forward है. तो 3 नंबर कोड दे. I'm going to switch portals. I'm going to change portals. You can see me changing the scopic portal into the instrument portal. And now give me that same carousel. Now that will go in through my scopic hand portal. So I'm going to use my left hand now and the scope in the right to switch portals and try and go a little deeper along the traversing route. There you see the route free. The capella. Because the slope of the facet, introducing a big curved one is a little difficult here. There, that what was sitting on the root is also gone. Chota de, chota curved de. Priyanka, do we have any questions from anybody in the audience? Chat मध्ये. Great. I think they are as troubled as I am. This punch de. I think our exiting route is decently freed. Traversing is okay. Fragment which has come out here. Now I'll go back on that side and we'll pay attention to this discal surface a little bit. Give me 5 more minutes, ma'am. Huh? We'll finish. Just hold it up here. Don't push it in. Let me come there. So we are again going to go back into the instrument portal and stop the switching of the portals and look down. Now when we look down, give me the Garrison 3 number straight there. We're going to cut away this little flavum here. Now, can I have the RF wand, please? Keep it on 2-2. Come on, touch blue. Stop, please. 1 minute. Yeah, come on. Touch blue. This is the discal surface which you're seeing. That was a tone PLL through which the fragment had come up. Stop, please. There's a fragment still attached here to the dura, but I won't go for it. It's not worth the headache. As you can see, from where the fragment came, we don't know. Touch blue. It's God's mystery now. After so many months, annulus appears to have healed itself. Okay, give me a dissector. Let's show the viewers. Can you see this rough dural edge with all that plastered disc to it? I don't want to really risk it because I can have a tear. But whatever must have been coming out from here somewhere that has healed itself. Maybe this is the weakness here. I don't know how much sense it makes to go back in again. Okay. What was troubling him was this fragment sitting on this root. There's again a piece here which we are not able to get out. But the rest of the root is free. Nice and free. So rather than risk a root tear, which can be very painful, and give him root dysesthesia, which is also not an option. Let us just end our surgery here. I hope you guys have had a great time. Give me a disc punch, please. Yeah, that little tag which we had freed, that also we have removed. And this little bugger also freed. So I think we have done a decent job. And we've left our little band in the center for posterity. Classical Hoffman band in the center, midline. Okay, guys. I think we've ended our surgery well. We've retained some of the phlegm on the other side. I don't know what that piece is, but whatever it is, it has to come out. मला angle दे. कुठला कचरा कुठून आला? Thank you. Thank you very much. See you in Bhubaneswar, guys. I hope you enjoy this video. मला जरा disc हे दे. I'm going to try and burn this down a bit. Touch blue. Stop, please. Give me a ball tip hook. A tag of disc, old disc tissue, hard disc tissue. I don't know. I don't think it's worth going for it. See? Stuck in the axilla. It's a small piece. I think we can ignore it. Okay? That's your discal surface. That's your midline. Gone right till the midline. Okay? On the floor of the discal bed. See? Showing the undersurface of the dura. And that had stuck fragment to it. But let it be now. I think it should not fool around. Give me. Because an anterior dural surface tear, I think I will be very, very scared. I think we managed it quite well. At the end of the day, we can say this was a job well done. Thank you, guys. Exiting route once again, traversing and exiting. Above exiting where the fragment had come out. Thank you. Bye bye. Have a nice day. Can I have some local steroid, please? Put it on the group. Those who wish. If anybody has any questions, then we'll generate a Zoom link in 10 minutes. If there is nothing, then good night, everyone. चालू है ना अजून? Can you see the small amount of bleeding and oozing coming has stopped the fluid? I'm attaching the Priyanka, can you show the screen? Yeah. I'm attaching the other side and just pushing in the steroid. Can I have some water for a second? Pump चालू कर. Yeah, this is just to flush the steroid in. Okay, see it's all flushed in nicely, and now I can pull my scope out. Thank you. This is the amount of bleeding that we had in the whole surgery. Nothing much coming out. Yeah. Okay. Can you put on the light, please, guys? Lights on. Sister, infiltration with ropivacaine in the wound, 0.75. And can we have some one single stitch closure? So, किती व्ह्यूज आले 59. म्हणजे खूप लोकांनी बघितले.